think I can use this. Good afternoon, or morning. It's officially afternoon in 1 minute, right? I'm Elaine Murado, and I'm in the Department of Health Systems Management and Policy. And we are very pleased to have today Dr. Nilay Shah from the Mayo Clinic to be talking about patient-centered translation of evidence into practice. This seminar is actually a combination of 3 different seminar series all coming together. So I wanted to acknowledge that this is part of the Health Services Research Seminar that the Department of Health Systems Management and Policy and Public Health sponsors. In collaboration, this particular session is in collaboration with the Impact Series seminar, so some of you may be attendees from that. And we are also sponsoring it from CRISP, which is the Center for Research and Implementation Science and Preventive Services. So some of you may be representing that. So hopefully what you hear today will meet the needs of many different audiences on campus, and it's exciting to have all the different points of view here today. So Dr. Shah is a health services researcher in the Division of Healthcare Policy and Research at Mayo Clinic. He is an assistant professor of health services research in the College of Medicine there, and the co-director of Translating Comparative Effectiveness Research Unit, which is part of Mayo's larger translational science activities, their CTSA. And that's actually how I got to know Dr. Shah, was through the CTSA consortium. There is a key function committee on comparative effectiveness research, and we're both members there and got to know each other there. His research focuses on improving chronic care delivery, and he incorporates a wide range of methodological tools. We would say mixed methods, including mathematical models, observational designs, as well as prospective trials. And he's been involved in numerous studies to test the role of shared decision-making for patient-centered knowledge translation and for translating comparative effectiveness research into routine clinical practice. So I want to welcome Dr. Shah. He will be available afterwards for questions if they're not answered during this session. And we are also passing around clipboards for those that might be interested in the seminar series or more information on implementation science. So with that, I'll let Nilay get started. Thank you.
Elaine, thanks so much for inviting me. It's great to be here, and it's been great meeting a lot of the people this morning. So thanks again. So I'm going to be talking about sort of wide range of work we've been embarked on at Mayo over the last 7 or 8 years, and some of our experiences with that, with a specific focus on how do we translate evidence into practice in a patient-centered manner, and what we've learned over this time frame. So just in terms of disclosures, a lot of the work funded here, or that I'll be talking about today, was funded through multiple sources, through HRQ, NIDDK, Foundation for Informed Medical Decision Making, American Diabetes Association, Mayo Clinic Foundation, and then Mayo CTSA as well. And I want to just acknowledge so our research team is multidisciplinary, includes many different people, but these are some of the key people that represent some of the work that I'll be talking about today. So just to sort of start out, this is sort of the underlying mechanism that we've thought about in a lot of this work, is how do we get evidence-based medicine into sort of knowledge that's used routinely into practice that leads to better patient outcomes. And this is a framework that we've found very useful in sort of thinking about this work. So if you think about it, and at the end of the day, what we want to get to is how do we get the patients to agree to adhere to achieve the outcomes that are most important to them. And so here's a sort of, when we start out, there's clinical studies and systematic reviews that are generated routinely. So here I've used a couple examples that we've used in our translation work. So there's a comparative effectiveness of diabetes medications. There's the angioplasty versus optimal medical therapy. The interesting piece here, there was a piece by Ian Chalmers and Paul Glasgow about a year or two ago where they published on they looked at over the last 15 years or maybe longer, about 30 years, how much evidence is being generated And they said on a daily basis, there's 75 trials that are published and 11 systematic reviews on a daily basis, and as of, I think, 2010 or 2011. So that makes it difficult of how do we get all that evidence into practice in a meaningful way, in a systematic way. And so that's where, one of the aspects of it, obviously, is getting the clinicians aware of it. And so that oftentimes happens through guidelines, aware of the evidence. So this is the ATP3 guidelines related to, use of managing lipids and so forth. So that's, first is how do you get them aware of it, and then to accept it. And that's a challenging piece, So depending on where you are sitting and depending on what the evidence is, different clinicians may believe the evidence differently. And then oftentimes this acceptance or applicability, usability is driven by insurance companies. So what they cover, what they're willing to let at least pay for, that determines how this evidence gets used in practice. And then from there, once you know that, so this is sort of a view of one of the aspects of our electronic medical record, is you then how do they, once, it's accepted, applicable to their patients, how can they act on it? And here, for example, you get the evidence incorporated. This is a clinical decision support aspect of our clinical record. So there you can incorporate the evidence. So that's another way of how we get this incorporated. And then finally, the last piece of it is, once you get the clinicians to buy it, is how do you get the patients to agree to and adhere to those treatments that are recommended? And so this is a key issue, at least as we think about it, is, 60% of patients typically don't follow the advice here. And, it leads to quite a bit of wasted or misallocated resources to a tune of estimated up to $290 billion or more. And leads to poor health despite the cost and side effects because of the non-adherence. And potentially complicates the patient-clinician relationship when there's non-adherence going on. And so this part of where we're going with this is there an aspect of non-adherence related to the lack of knowledge from the patient of why they're taking the treatment? What's the risks and benefits? And so that's part of what we have tried to achieve in a lot of the work we've undertaken over the last few years. And so this is sort of a more ambulatory-based framework, but essentially the historical evidence is, the patient and the clinicians begin the consultation. And then the patient leaves the consultation with the prescription of whatever that treatment might be. And at some point down the line, they make the decision whether to take the medication or not. So there's this issue of primary non-adherence, which is you never fill that prescription. So there's some evidence that suggests that about 20% of prescriptions for hypertension medications and diabetes medications are never filled when they're prescribed. And then there's decisions down the line to get refills. So 6 months down the line, a year down the line, they may decide not to take the medication. And so part of our goal is, can we bring that conversation within that encounter and before the decision is made, so clinician and patient can discuss the medication options. If the patient's on board, does this lead to better adherence, for example? So that's part of the framework here. And so the way we achieve this is to try to take the research evidence for whatever that topic is, and I'll present some examples, to create a decision aid, but one that incorporates patient values and preferences. And I'll talk about the process we go through. And this decision aid then gets brought back into the exam room to have this conversation, again, more, within the encounter as opposed to after the encounter, and have the patients engage in making that decision. So the typical mechanism that we've used in doing this work is from the evidence synthesis, and we observe clinical encounters for whatever that decision is. So a number of our investigative team observes the encounters. How's the decision made? What's the process of the decision making? What are the issues that patients and clinicians discuss? What may be potentially missing from that discussion? So we take that, take the evidence, take these initial observations to create an initial prototype. And the prototype is then shared with clinician stakeholder groups, with patient stakeholder groups to provide some feedback. And then clinicians actually use it in real encounters where these decisions are made. We observe them through our designers, through some of the investigative team, get some feedback, and go through a process where we continually modify it until we feel like it's creating the discussion that we would hope that research evidence might have. Now, this is somewhat of a subjective process. There isn't very great science underlying it, but it's, at least we've found it to be a useful model to develop these tools. And then ultimately, after we develop it, we typically test it in randomized trials to say, okay, what does this mean in terms of the patient experience of care, the clinician experience with using this tool, and ultimately, can we really get this routinely incorporated into clinical care? So one of the aspects that we're still challenged with, it's not completely solved, is, okay, we develop these tools that we use and we test them in trials and so forth, but at the end of the day, after the trial is done, if the clinicians say, this is even if the trial results are positive, they decide it's not worth using it, it's sort of a lost cause in the sense that spent a lot of effort, but if it doesn't get routinely translated. So that's an issue we're still struggling with, and I'll talk about that more towards the end. So our first work was creating what we call the diabetes cards. And, so initially we started out by observing how do discussions about diabetes medications occur between patients and clinicians. And at the same time, there was this HRQ-funded systematic review on comparative effectiveness of diabetes medications that came out. And essentially what it found is that most of the medications worked similarly well, but there were differences in some of the adverse effects that patients may experience, as well as how you may take the medication and so forth. And the iterative process we went through, and this was, at least from our perspective, a very valuable learning experience, was what we called essentially getting to a choice architecture stuff. So how do we present these choices to patients that makes it meaningful for them to engage in this discussion? So we started out, again, taking our research evidence and the practice review with the Diabetes Patient Advisory Group, tested in life setting. So this was our first iteration of the cards that we came out with. We called it the baseball cards. And, it was basically each drug and their characteristics, statistics that we presented here. And when it was done, we had the prototype. We're like, oh, these are beautiful. They're going to work great. We'll be using them routinely. And so then we give it back to clinicians, go observe the encounter, and what happens is they start the encounter, the patient and the clinician brings out these cards. And they both sort of admire them, looks beautiful, and then just put it to the side and go about their usual business, and we realize, well, it's not doing what we were hoping it would do. So we went to sort of the next iteration, which we call the narrative cards. So we took the same information but presented it in a slightly different way. Again, similar experience. They looked at them. We watched about, I think, 8 to 10 encounters. Clinicians and patients looked at them together, and no real uptake there. So we came back both to our clinician advisory group, the patient advisory group, and sort of said, we need to brainstorm this. What is it that matters? So essentially, this is sort of a whiteboard exercise. Sort of, we started just from, essentially went back to scratch, said this is not doing what we thought it would do. And so turns out what we learned through the process is what was important to patients wasn't the medications, it was the issues around the medications. And so as a result, our final iteration of this was the issue cards, and that seemed to work much better than what we had originally seen with the other two things. Now, interestingly, you'll see our last iteration of this. So this is our first iteration, so it doesn't even include all the current medications. So there's a whole process of updating the evidence. But also an additional card. So we did our initial trial, and one of the things that came out was in our decision aid group, the intervention group, there was much more questions around the cost of the medications by the patients as opposed to usual care. The usual care, was interactive process. And one of the things we learned through the we videotape a lot of these encounters to the extent that physicians and patients are comfortable with that. And so it gives us a lot more insight as to what's happening in the conversation around these decisions. And so as we learned a bit more, one of the issues, the cost issue, kept on coming up. And so our final iteration that is currently being tested in a larger trial has a cost card in addition to now the challenges, and we're not sure that this is perfect. We went through, again, with our patients, how do we represent cost? There's different payers, different costs to everyone. So we ultimately tried to do it so that, well, what's generic? What's available on the $4 plan? So giving sort of the minimal information to at least know what's going to be relatively cheap here. And so this was our final iteration of these cards that, we tested the previous iteration without the cost card. And what we found in our initial pilot trial was the cards were more helpful. It significantly improved knowledge for the patients. It increased patient involvement in the discussions. And so we observed the videos is one way we got it, but also had patient respond in terms of how involved they were in the decision making. Interestingly, there was no difference in adherence, one of the things that we sort of hypothesized going in. And part of it may be, I guess for lack of a better word, our Rochester, Minnesota sample, our control group had perfect adherence, so there was no improvement to make there. So it was challenging. And then over a 6-month period, and not surprisingly, it had no impact on hemoglobin A1C values. So this pilot trial was published, if you have more interest, in Archives of Internal Medicine a couple of years ago. And so subsequent to that, what we did, and I won't get into this, but if you have an interest, I won't bring this up right now, but these cards we have created, all the initial trial was on a paper-based card, so it's these laminated cards that physicians can write on and erase and so forth. But we have an electronic version if you have an interest. It's diabetesdecisionaid.mayoclinic.org if you want to look at it there. We haven't tested it out. One of the questions that I was talking to Dan Matlock earlier today, and he asked, is there differences? And we don't know if there's any differences how the electronic tool works. We've had clinicians use it on iPads as well as on the video screen. But if you have an interest, please go ahead and look. It's diabetesdecisionaid.mayoclinic.org. And so right now, where we are with this is, as a subsequent work related to that, we're doing a 24-site cluster randomized trial of these cards. And really, beyond the initial sort of pseudo-efficacy, we wanted to better understand, is this something that practices will take up, clinicians will take up in a routine, for routine clinical practice, or is this, again, as I mentioned earlier, just a novelty that doesn't get too far? So right now it's being tested in all of these sites across Minnesota. It's being used. It's been a really interesting experience at our Safety Net Hospital in Minneapolis is using it. Couple of the inner city clinics in Minneapolis are using it, as well as a lot of the rural clinics, and then, sort of more of the Rochester, actually, for the reasons I mentioned earlier, Rochester does not have a site for this, so we are not testing this in Rochester. So one piece is just to generate more evidence of, really does it in this broader community affect adherence to treatment, for example. But also, how long do clinicians, so we're going to look beyond where we stop recruiting patients to see, do they continue using it? Do they find value in it? So that was sort of our first foray into this work. And so our next issue that we went to was looking at the issue of statins and whether one should take a statin, translating essentially the statin guideline into a decision-making tool. Now, oftentimes people would suggest, well, really, is there a decision that everyone should be on a statin? And from our perspective, again, we went back to a couple issues there. One is the non-adherence. The non-adherence with statins is very high. Up to 50% of patients stop taking it for primary prevention within 2 years. So we're hoping to engage patients. And two, oftentimes the guidelines if you translate the guidelines into risk, it turns out to be low-risk patients, people with less than 10% risk of having a heart attack in 10 years who are being prescribed these medications. So can patients engage as what's their right amount of risk at which they want to start initiating these discussions? So, and then finally, the other issue that we really were concerned a little bit, this was a paper by Dennis Coe and others a few years ago, but there's this whole risk treatment paradox with statins, is that the lowest risk people are treated at the highest rate relative to the highest risk people. So can we flip that as well by getting the right sort of risk treatment concordance using patients engaged in decision-making here? So again, this is sort of the model that I talked about. This is the visualization, from the visit observations. Again, we went through the process of how do we present this information to patients. We went through the collective ideas of the group and created our initial decision-making tool here. And should I take statins? It was, again, a paper-based tool that we used a sort of risk calculator, the UKPDS risk calculator, to calculate individualized risk for each patient involved in this trial. So our initial decision aid looked something like this. How does the risk of having a heart attack calculated? So having that discussion with the patients. And what's the risk and benefits? So here's someone with a 20% risk of having a heart attack in the next 10 years. So, a lot of the data suggests that it's, presenting percentages don't translate well with patients. So, so we presented as pictograms as well as absolute frequencies here, and give patients what's their benefits as well as what are the downsides of taking these medications, and then what do they want to do now. And so here, again, this trial showed significantly improved knowledge amongst patients, that they knew much more about their risks. They were comfortable with their decision at a much higher rate in the intervention group compared to usual care, even for a decision like statin. It led to slightly increased trust with the patients and physicians, and we found more. Even though it was a small trial, it was about 100 and right around 100 patients. There was more of a risk treatment concordance here. And then at 6 months, when we looked at adherence, the adherence was higher in the intervention group, at least in this case. And so since then, we have created a combined tool. The one tool that we also created was aspirin. And that's where we sort of presented this was, we used the pictogram to present it. This was 1,000 because of the low risk of bleeding, but we wanted to present the risk of bleeding. So this has not been tested, but we have our online tool. Again, it's statindecisionaid.mayoclinic.org. If you go there, it combines the aspirin and statin decisions together. So especially for people who are not on aspirin already, it doesn't make sense to go on statin because you get quite a bit of cardiovascular risk reduction from aspirin. So that's some initial work. You feel free to, this is what our online tool looks like. So it presents the person with their current risk, the risk by taking a statin, for example, what are the side effects, daily routine, cost, and other benefits. So, as you have questions, feel free to email me. I'll have my email at the end of the thing here. So our next question was the issue of bisphosphonates for women with osteoporosis. And this was another, and one of the things we've learned through each of these is it's not the exact same thing. You learn different things, and different things occur over different periods of time. So here, this is a graph showing adherence to bisphosphonates after initiating them. And so there it's 100% down to, within 169 weeks, it's down to 20% adherence. This is based on medication fills. And there's data that suggests that actually there's a relationship between adherence to medication and risk of fracture. So again, we sort of tried to use this information and getting both women engaged in this, primarily women engaged in this discussion. So here's our statin decision aid, and again, it's very similar to the osteoporosis decision aid, very similar to statin decision aid. Our designer that we worked with decided that bones would be nicer than happy faces, so we went with the bones here. And again, it shows the same, what's the risks and what's the benefits, what's the risk of going on statins here, and then what would the patient like to do. So interestingly, we found most physicians found it very useful to use it. It increased consultation time by about a minute, less than a minute in some cases. But I'll get back to this issue. This is a big issue when we try to sell this to practices, to test these tools. They always say how busy they are and they can't take it up within their practice. There was significantly improved knowledge and risk estimate, which you'll see consistently through each of these things. However, there was no change in comfort or trust. There was increased patient involvement. And let me see if I have this right. So, and there was increased adherence for women who were in the intervention group and decided to start on bisphosphonates relative to those in usual care group. But the one thing that we found is there was no risk treatment concordance. So as you can see, the decision aid is blue, and actually the low risk group started at a slightly higher rate than the high risk group. And so that was a interesting piece. So why isn't there? Turns out it's even between the diabetes and the bisphosphonate trials, we learned just even patient participation is very different. You know, patients in the bisphosphonate arm were much more okay being videotaped, for example, for our study as opposed to the diabetes arm. And the only thing they said primarily is, let me put on my lipstick or do it. You know, but they were very comfortable doing that because they, I think, typically thought of themselves as generally healthy. And so we sort of went back and said, well, so we looked at the videos. Why did women decide not to initiate statins? And we were looking at, or not to initiate bisphosphonates, sorry. And we looked at how many reasons. So they typically gave 3 different reasons to physicians before they ultimately decided not to. So some of the issues were concerns about the side effects. So the side effects with jaw necrosis was a big issue. Distrust of medications. I won't take pills. They don't work. Patient knowledge against treatments. A family member with no osteoporosis complications or history of adverse effect with the medication. And health is good without other treatments. Again, going back to the idea that primarily the people that were enrolled in this trial were generally pretty healthy. And they also had issues of low value of potential benefits of going on this medication, even though it was presented in the pictogram. Too old to benefit. I don't want to live that long, for example, because we're presenting over a period of time. Limited knowledge of osteoporosis. If I felt bad, I would consider treatment. So that's the same issue as statins. People don't actually feel the disease per se. And the medication will not produce benefit. So again, the same issue. And then the cost of medication was, a couple people gave that as an issue. So it was a real interesting to understand that these were more a different set of reasons why women decide not to initiate bisphosphonates relative to what we'd seen with a couple of our other trials. So now moving on to this next idea, this is the recommendation of the medication bundle after acute myocardial infarction. So this was sort of our next big area that we looked at. And here you can see we looked out to 3 years after having an incident MI in our population, Rochester, and about 50% of the people stop one or all 3 of the medications that are recommended as part of the MI bundle. So this is, this was in the very well-insured group. They had very low out-of-pocket cost, and even then they stopped taking the medication. So what we did is we said there's 2 different ways that that people decide to be non-adherent. One is, structural intervention. So structural healthcare problems such as the cost, access, and the work the patients have to do to get the medication. So there was a trial in New England Journal last year where it was the MI-free trial where they removed the cost sharing for the trial for the recommended medications. And for statins, they increased the adherence rate from 41.9% to 49.3%. So this is the proportion of days the patients had the medications. And so this is very low rates of adherence. And obviously, this wasn't patient-level enrollment. It was more randomized at the plan level. So you don't know if some of them were not prescribed altogether. And then similarly, across all three medications, it was 19.3% versus 24.3%. So it was very low rates. It was significantly increased improvement with full coverage, but not great. So we thought about this idea of volitional non-adherence. So patients don't know what the risks or benefits are. And so we said, well, let's present patients with their risks and benefits. So what's their risk of dying in 6 months? This was, we used the GRACE risk score here. From after MI based on their risk factors. And what would the benefits be of going on all the recommended medications for them? And it was interesting. We initially sort of initiated this discussion with the cardiologists to say, we want to do the study. What do you think? And so cardiologists said, oh, we don't want to present this to patients. We don't want to tell them their risk of dying in 6 months. And then we also asked them in a survey, do they think their patients will be non-adherent? It was like almost all of them thought their patients were going to be non-adherent, but they figured they should just take the medication. So ultimately what we ended up doing was prior to discharge, the nurses and nurse practitioners reviewed this with the patients during the study. And so again, typical consultation time was 4 to 5 minutes during their hospitalization stay. It was tricky always finding the right time towards their discharge to, present this information. So that was a little bit tricky, but typically it didn't add too much time from the nurse perspective. Significantly improved knowledge and risk estimate, as I'll show you in just a second. There was not much difference in comfort or trust. Now, obviously, we were trying to use it within the hospitalization setting with maybe part of it. The patients were pretty well involved. We viewed videos again of this. They were very involved in the discussions as well as family members. And there was generally increased satisfaction. However, you can see this is the knowledge of risk and benefits. So we looked at the risk of dying at 6 months in the decision aid arm versus the usual care. So in the usual care arm, 1% of the people knew their risk of dying, or 2%, I think it was. Within 6 months, relative to, it wasn't great in the decision aid arm, it was 50%. And similarly, the benefits of medication, it was closer to 20% in the usual care arm, 70% in the decision aid arm. And the adherence, well, we can see, this was at 6 months, we looked at adherence to these medications. So for statins, it was, again, 79% in the decision aid arm versus 72%. 78% for all medications. So it's much different than the data I just presented with the structural intervention, likely due to two reasons. One, again, I mentioned our little bit biased sample in Rochester, Minnesota, but also people who selected to participate in this trial. So there's obviously much more of a selection bias versus the other one was sort of all comers. Here, it was interesting, where we thought some patients would benefit from this information, they decided not to participate. So there was definitely some selection into this trial. So here, I'll start with the case study. So this is another one of our examples, but maybe I'll start here. So 63-year-old woman presents to the ED with pain in the neck, going to her left arm, intermittent sharp twinges of pain in her chest, no ischemic changes on ECG, serial cardiac troponins were negative, past medical history for hypertension, migraines, breast cancer, and was a former smoker. And the question here is, with this risk factor coming in with chest pain, and if you actually estimated her risk of having adverse events, she was relatively low risk. What would you do with her? Would you want to stay in an observation unit and get fully tested? Would you rather just rule this out and go home? Would you have a follow-up with the physician? So, in the group here, how many would want to have the full checkup right within the observational unit right after, you got these results? If you were the woman and were shown what your risk was, low risk. If you were the patient, yep. And how many would want to go home? So what we did, so this, this was sort of work my colleague Eric Hess had led, and he came up with this idea of doing this study when he compared rates of going to observation units for women or for patients with low risk in Canada and U.S. So he looked at 3 centers. In Canada, it was approximately 20% that were either in the observation unit or admitted, versus the U.S. was over 90%. So huge differences, and at least what we saw in the outcomes, so this was part of a systematic review, there was really no differences in outcomes between the two groups of having adverse events. So as a result, we created this chest pain choice decision aid. And so what it does is it gives you, gives the patient some understanding of what their diagnosis is, what are the further tests, specifically the stress test evaluation, as well as the potential risk from radiation from the additional testing. What's your personal risk estimate? So each patient's risk was individualized. So here, this person had a 3% risk of having an adverse event within 45 days. And so then they were given choice. What would you like to do? You'd like to go to the observation unit. You'd like to follow up with a cardiologist, follow up with a primary care physician, or just go home, or let the emergency physician make the decision that you don't want to be involved in the decision. So that's one of the concerns, is oftentimes these decisions are being forced on the patients. Patients don't want to be, have to be on the line to make these decisions. And in this case, so there were 205 patients in the trial, 100 in the intervention arm. And the intervention arm, every one of them, none of them let the emergency physician make the decision. They wanted to be involved in the discussion around it, so just to give you some context there. And so the summary of these findings was significantly improved knowledge, again, consistently across all of these studies, more comfort with the decision, greater level of engagement, and high levels of satisfaction for the patient relative to the usual care arm. And as you can see, in the decision aid arm, it's still not great. Compared to the usual care, about 80 or 76% were admitted to the observational unit versus 57% in the decision aid arm. So it's still not necessarily like Canada, but it definitely decreased the use of additional testing fairly significantly. And the hospital admission was similar between the two groups. Now, one of the things that we noticed is that over time, this was randomized at the patient level. And so this is a big issue with these trials, is how do you randomize them to prevent contamination? And so what we saw in the usual care arm, where the clinicians didn't have the risk for their patient, they had started changing their behavior to start discharging patients towards as they got more experience with the decision aid, even though they didn't have that same data. So it was an interesting, so at least our partial hypothesis was that the rate would have been higher in the usual care arm had it been like more of a cluster randomized trial. But we don't know. So that's one of this work is going to be now continued in a PCORI-funded grant as a cluster randomized trial. So this is some ongoing work that we have ongoing, or just either in trial phases where we don't have the results, but there's this idea of, well, what antidepressant do you take as a patient? There's a number of different options that work in a variety of different settings. And so, again, to use our model that I presented earlier, we conducted an evidence synthesis of what's available. This was using the HRQ comparative effectiveness review for the antidepressant medications, and created what we call the depression choice decision aid. Looks sort of like the diabetes, although it had slightly different nuances as we worked through with our stakeholder advisory committee, patient advisory committee, set of different issues. So this is being tested right now in a 10-site randomized trial, and so I think we conclude recruitment at the end of this month. But this is another one that's ongoing. The other one is this idea of angioplasty versus optimal medical therapy for either class 1, class 2 angina or class 3 angina. And as there's been quite a bit of data, here's some data from Dartmouth Atlas, there's quite a bit of variation around the country. And at least our general experience is that this is not driven necessarily by patient preferences. It's probably driven by clinician behavior that may vary across the country. So to go through this process, we created, again, a decision-making tool to have patients engage in decision of what they want to do and how do you translate this evidence that was generated from the comparative effectiveness review. We know there's quite a bit of variation. What's their risks and benefits? And so this is, again, a trial that's ongoing where we are currently accruing patients. And so just to give you a sense of where we've done some work, so the statin choice, I briefly mentioned the diabetes medications. The aspirin choice we've not tested in a trial, but it's been developed. Depression choice, we've done some work around genomics. So how do you engage patients in discussions around genomics? It's much more difficult than one might imagine. And so that's been an interesting, because there's a whole movement nationally to put genomic data in electronic medical records. And it's challenging because, one, for clinicians to know how to use it consistently, but also then to engage patients in decision-making around that. The osteoporosis choice, the ICD choice, the work here at Colorado that Dan's been doing is much farther along than what we had started. It was in the original design phase. We have a trial ongoing right now for smoking, decisions about perioperative smoking cessation. Chest pain choice, I mentioned, the MI choice. The hypertension one is still in the design phase. We've had a lot of trouble. It's not been as straightforward as we would have liked. The reason we started on the hypertension was all these primary care physicians said, well, you have one for aspirin and for statins and diabetes medications. It'd be nice for a diabetes patient to have one for hypertension as well. And because initially we thought there wasn't much of a decision. And then as we engaged clinicians around, or as we tried to synthesize the evidence and present it in a way, it's just not led to meaningful discussion. So that's been our learning on the flip side, that just because we've learned through other discussions, it doesn't always translate the same way for the next condition. So that's been an interesting piece. Well, we actually created a decision aid for rosiglitazone and the risk of the safety warnings that came out. Prostate cancer screening and early treatment, we have some initial work and going on there. The PCI versus medical therapy I mentioned. The mammography, less than 40, one of our trainees is currently developing it, but I think she might have started the trial. This is, again, taking the USPSTF guidelines and how do you translate it into practice so that the women and the clinicians can get into discussions of whether they should have, yeah.
So what does the smoking choice positives look like? I mean that's an example of a choice where clearly the medical evidence is all in one direction.
Right.
How did you balance that one in terms of patients?
I think it's very much focused towards what's the benefit of going on the smoking cessation therapy prior to it, but also the long-term effects. And then the downsides were really what's the effect of those treatments. We didn't focus so much on
So it's smoking cessation.
Smoking cessation piece, yeah. So it's focused on using perioperative time frame as a good time frame to sort of engage patients in smoking cessation. So these are some of the things that are ongoing. I think we may have a couple other new ones that I can't remember. So we are trying to build this evidence. A lot of the key is we don't try to come at it and just say, oh, we are going to do this, but rather engage clinicians and have clinicians who believe this will help them make, because ultimately we want to test them. And so we need to have engaged clinicians in that area to work with us to do that. So that's the way we've sort of gone forward with this. So the success of the decision, what have we learned through that? One of the issues that we've learned is fidelity. So a lot of the videotaping is not just to say what's the qualitative nature of discussion, but how are these decision aids used? So I'll actually scroll back quite a ways here, but one of the ones that was interesting was some of the videotapes around the statin one. There were clinicians who would use it basically say, if you don't take this medication, you're going to be one of these red dots. And so really it's not, to look at the fidelity, it's really sort of a scare, and so we're trying to look at how do we keep the fidelity of this intervention in place. And so it doesn't, So it does improve fidelity, to having this information translated, but not as great as one might engage, but I think it makes the process. One of the things we haven't learned a lot about is a lot of times these measures are based on 1 or 2 uses by the clinicians. So is there a sort of learning by doing where it takes 4, 5, 6 uses for clinicians to get comfortable in how to incorporate this? So that's something in our current trials where we have clinicians with multiple uses we're hoping to learn a lot more about. Creating a conversation. So this is, what's the rate of patient engagement? How does it create an interaction with the patient? Significantly improved using mostly qualitative methods is called the option score that was developed by Glenn Elwyn is what we've used. And there's about a 17% increase in the conversation that's created by the use of these tools. The adherence, as I mentioned, has been mixed. So we saw improved adherence with the osteoporosis and the statins. Not so much after the MI or the diabetes medications. So part of it is we need to do it for larger trials, powered for that outcome, and so forth. And then the implementation. So this I won't get into much is, okay, so now we have it tested. How do we get it into practice? So here's the version for the statin. This is our clinical decision support tool for primary care at Mayo. So basically, the way we've incorporated this is the Framingham score is calculated, and the patient can just press on this button to get the decision aid for a statin. So that's one way of the implementation piece. Our ultimate goal with the diabetes and the 24-site trial that's going on is to test how long physicians keep using it beyond the end of the trial. And so we're using something called the normalization process theory to better understand how these tools normalize into routine clinical practice. So we'll learn a lot more there. This we haven't tested explicitly. The only way we've been testing is how often it's used. And without any active dissemination, the use has been, at least from our perspective, much higher than we would have expected. Same thing, this is a web-based, again, interface to do more broader dissemination. The big advantage, so here you have to input each of the values to calculate the risk for the patient. The nice thing about this is it's just a click. There's no additional work for the clinician. It's built into their workflow. And so just to give you an overall summary of what are our lessons learned over all these years. So user-centered design happens in the field, takes multiple iterations and some expertise to make that piece happen. Challenges with evidence synthesis and changing evidence. So this has been especially very true with the diabetes medications where we are getting new safety warnings or new medications being added. And so how do we get it? We have to continuously keep it up to date, and so that requires some work, and we're learning about that over time. Testing decision aids in usual clinical settings is tough because you don't know what the right decision moments are. So as simple as it sounds, especially for chronic decisions. So for the chest pain or MI, it's not that difficult. But when you start thinking about the osteoporosis or statin or diabetes, when is that decision or discussion going to occur, and how do you identify that, especially test this? So that's been challenging to understand. The repeated use, so what happens with repeated use? That's unclear. So one of the common challenges that, when we present as clinicians that comes up is, we don't have time within our practice to incorporate one more thing, and typically once they use it, at least by and large, our experience has been they want to continue using it. But the initial point is difficult. By and large, across our trials, it increases time by about 1 minute to 2 minutes. But sometimes in a 10 to 15-minute encounter, that's a fair amount of time. So one of our hope is over time, by engaging patients and letting them know about their options, that it's going to decrease time in future visits. Yeah.
Do you have any sense of that increase in time? What portion of it is the physician actually trying to implement the tool, and what proportion of it is actually more engagement from the patient because they actually have increased knowledge to enter into a discussion?
Yeah, I think it's twofold. One is oftentimes where we've measured this time, the clinicians are using it 1 or 2 times. So they're fumbling a little bit with how to bring it in. But 2 is there's more questions. There's definitely much more questions from the patient. And so some clinicians would prefer not to have that. And so there's always that challenge a little bit. But what's happened to us is now as we are running more trials, clinicians who participate in past trials say, No, it's because we were doing cluster randomized, so they may be randomized to usual care. And they said, if you're usual care, we're not going to participate in the trial because they want to continue using the tool. So at least at some level, it's positive. It's not across the board, but at least we're hearing that from some physicians. Again, the decision aids have increased knowledge and patient involvement consistently across all of these different areas that I mentioned today. The adherence is mixed. The clinicians and patients reported high levels of satisfaction, but the culture is important, and the leadership especially, to promote this culture, especially if you want to get it routinely implemented. One of the sites that we went to for the diabetes trial, the lead clinician was in the room. It was through their primary care executive committee that had a patient on it who had diabetes. So we actually experimented using the tool. The patient was like, "Oh, this is wonderful." So we went to the clinician and said, "Well, what do you think?" He's like, "No, I don't think we're going to participate." Oh, and the patient was still there. "Oh, we know what to do. It's algorithmic. You go metformin, Januvia. It's set. There's no decision to be made here." And so that was interesting. Januvia is one of the newer, more expensive medications that he was saying would be second line. There's no discussion. So I was talking to one of the other clinicians in his practice later, and he said, well, his wife is a Januvia rat. But it's been an interesting experience there. Some of the work in progress. So, better understanding what's the level of evidence that's necessary to get this into routine practice. So while we are getting some of these tools in, is there a certain level of evidence? What's good enough? We don't want to burden practices by adding more tools that may not add value. Challenges of broad implementation and routine use. I think there's a lot of learning to be done. And then ultimately, as I mentioned, the right place and time to engage patients is tough, especially for chronic conditions. So feel free to email me. Also, Catherine will have a copy of my slides, and so feel free to email her if you want a copy of the slides, or this will be available from this website. Thanks so much for having me. I appreciate it.
Well, I'm Julie Marshall. Thank you. I'm wondering, it has to do with your last bullet. We found in one of our projects that with patients with diabetes, there's a lot of emotional coping with the condition, or even, not accepting the diagnosis sometimes for years. So how does this kind of fit with?
Yeah, so one of the process that we've taken especially for diabetes trials, is we do a follow-up patient qualitative interviews right after their visit, and then 6 or 8 months after that initial index visit where they were enrolled. And it's been fascinating because we talk about their decisions, take medications, and all they want to talk about is sort of living with the disease, or it's not as much the treatments that they are interested in. And on the flip side, one of the things that people keep on bringing up is, why don't you have lifestyle and diet on these decision aids as options as well? And one of the reasons we don't is evidence is not, there isn't great evidence to present to patients in that realm. But the flip side of it is, when we present this to patients, oftentimes patients come back and say, I think I want to work on lifestyle and diet at higher rates in the decision aid group than the usual care. So it sort of activates them sort of in a different way to engage in that discussion. But most of these patients are, in our trial, we restricted to patients who've had diabetes for at least a year. So it doesn't get to the sort of long-term denial group, but the first treatment we typically, or people newly diagnosed typically have not enrolled in these trials. So that's sort of roundabout way. I don't know if it completely answers your question, but some different ways. We try to learn mostly through qualitative work how patients deal with it. And I think we should have, from one of our trials, some of that work coming out in patient education and counseling pretty soon.
Thanks for a great talk. I had a question about what the training looked like for the providers before they start using one of the tools, and if you had measurements of the kind of collaborative style, the spectrum of that among the providers, and if so, if it correlated with results?
Yeah, we tried to keep it very minimalistic training. So right now, basically what we have is a 2 or 3 minute YouTube video that they just viewed prior to their first encounter, and then they have like a pictogram way of how sort of these tools are designed to be used. Like one of the things with the diabetes cards that I didn't mention is oftentimes what the clinicians want to do is take the cards and then just go one by one for each card with the patient. Well, that's not the goal. The goal is to sort of say which issues are important to you. And typically by the third issue, the patient knew what they were going to take. So we try to do really brief, maybe 2 to 5 minute baseline education prior to their first visit. And the other thing that we haven't really done but have discussed amongst us is, should we do a little bit of audit and feedback based on the videos that we have for the clinicians where they might, and we aren't sure if they, how that would be received, and so as such we haven't done that. In terms of how well they are at engaging patients, so we are using both our fidelity scores as well as what's called the option score in creating the engagement with getting the patient engaged in discussion, but how high their fidelity was in using it. And that's in the depression and the diabetes trial that's ongoing. We'll be looking at what effect that has on some of the outcomes, but we don't know that at this point.
Yeah, I could see, and you mentioned this quite a bit, with the patient education component and how that might affect primary adherence. But what about longer-term adherence? Did you look at the actual probability a particular drug is prescribed, and if that changed due to the intervention, so the communication with the patient led to better matching for, say, diabetes or statin?
In our initial trial, diabetes trial, for example, the distribution of drugs used had not changed. But that was, 100-some patient trial. Now, the current trial that's ongoing will accrue over 400 across multiple practices, so we'll be able to see whether that distribution changed a little bit. But it's interesting. It does create different issues. So we had an example of a 94-year-old gentleman who, when this was presented, the diabetes cards were presented, he said, I want to go on Byetta, which is one of the injectable drugs here. So let me just go back. So the doctor said, why would you want to go on Byetta? I mean, it's expensive. And plus, you never want to take insulin. You don't want any injection. And so this was, one of those interesting moments, and what some clinicians may not like here is so the biggest issue that was reviewed. So you can imagine all these issues that are presented to the patient. Would you guess what's the most common? What's the first issue patients typically look at here? So the first issue that's at a high level picked is weight change, right? Which in the usual care arm is almost never discussed. And so they, so this guy looked at this and said, ooh. And so he said, Doc, I'm going to be going to a nursing home in 6 months, and I want to lose some weight. There's going to be a lot of women there. It was really an interesting example. So there is some issues like that do, but it's much more anecdotal. But if you look at the full distribution in the small trials, we haven't seen much there. That's interesting.
I was remarking to Dan that you don't have you have an intermediate endpoint of blood sugar, but not like decreased heart, actual patient-oriented benefits.
So that's a really important point, and that I didn't mention here is there's no evidence for these medications on the hard endpoints like heart attacks or even patient-reported outcomes related to any of these medications. So that's like a missing component, and that's a good point, and we presented that to when we present this initially to our patient advisory group and said that there's no evidence there. They didn't bring any feedback up, but that's a missing point that obviously doesn't get discussed in usual care, but even in this arm. And one of the interesting things and largely I think it's driven more by the quality improvement movement more than anything else. We did a survey about 2,500 patients and asked them to rank their issues that were most important to them for their diabetes. And so we asked them, is it preventing a heart attack, preventing stroke, preventing kidney failure, lowering your hemoglobin A1C? We had 10 or 12 different things. What was the number one issue for patients? Lowering their A1C. So they didn't care about heart attack, stroke. That's the messaging, right? But no, in this case, it's one of those missing evidence pieces, and I don't know. It'd be interesting. We'll have to ask in the qualitative interviews we've got going on, but I don't know to what extent we ask them about how important do they think these hard endpoints would be for them. Yeah, that's good. Thanks.
I don't know diabetes that well, but I've heard people with diabetes say they feel better when their blood sugar is under control. So is that true, diabetes people?
Well, yeah, because there's also the flip side of their blood sugar getting too low, and then them feeling worse from that. So
there may be a benefit just in having their blood sugar under control.
That was my other point to Dan, was that there's nothing about how it makes you feel either on these cards.
Yeah, so the one that does apply that people tend to pick at after weight change is the low blood sugar. So they're more interested in getting worried about their blood sugar getting too low and not feeling well from that. Interestingly, where we see the blood sugar card here, that's used maybe in 40% of the cases in the decision making, and there it's not, the evidence is pretty similar across all the drugs. But patients typically, their top three are weight change, low blood sugar, and a daily routine. So it's interesting. Not what, one of the ones at least going in, we thought it would be side effects, and the side effects almost never gets used.